Today, we're going to demystify one of the most fundamental treatments in all of medicine, oxygen therapy. We're going to climb what's known as the oxygen escalation ladder, exploring the how, the why, and maybe most importantly, the when. Let's dive right in. We're starting with this quote because, honestly, it's the single most important idea to get your head around. Oxygen isn't just some comfort measure we use to make patients feel better. Nope, it's a powerful medication, and just like any other drug, it has specific doses, targets, and, yeah, potential side effects. Once you start thinking of it that way, it changes everything. So, here's our game plan. We'll kick things off with that core principle, that oxygen is a drug. Then we'll get into the actual tools, starting with the common low-flow devices before moving up to high-flow and high-precision systems. After that, we'll talk strategy, when to escalate care, and we'll wrap up with 5 simple rules for making sure you're delivering it safely. All right, first things first. Before we can even think about using all the fancy gear, we have to understand the fundamentals. This is really the bedrock of doing oxygen therapy safely and effectively.
So, what are we actually trying to accomplish here? Well, at its core, oxygen therapy is all about one thing: treating hypoxemia. That's just a medical term for when there are dangerously low levels of oxygen in the blood. So, we're giving a patient a higher concentration of oxygen than the 21% they'd get from just breathing room air. It's a targeted treatment for a very specific problem.
And how do we know if a patient even has that problem? That's where pulse oximetry comes in. You know, that little clip on the finger? It measures SpO2, or oxygen saturation. And this measurement is so important, it should absolutely be treated as a vital sign, right up there with heart rate, blood pressure, and temperature. It's our real-time window into how well a patient is doing.
Okay, let's get into the hardware. We'll start with our low-flow toolbox. These are the devices you'll see every single day. You can think of them as the very first and most accessible rung on our oxygen ladder. Now, what's the big difference between low-flow and high-flow systems? Well, it really comes down to this. With low-flow, the actual percentage of oxygen the patient gets, the FiO2, is just an estimate. It's variable because the oxygen we're giving mixes with room air, and it changes depending on how fast or slow the patient is breathing. High-flow systems, on the other hand, are designed to deliver a precise, known amount of oxygen no matter what the patient's breathing is like. That distinction is really key.
And here are the 2 workhorses of low-flow oxygen. On the left, you've got the nasal cannula, and on the right, the simple face mask. The cannula is usually way more comfortable. You know, a patient can still talk and eat with it on, which is great for lower oxygen needs. The mask can deliver a bit more oxygen, but some people find it a little confining.
This chart lays out the whole low-flow hierarchy perfectly. You start at the top with a nasal cannula and work your way down. As you go down the list, you can see that both the flow rate in liters per minute and the approximate oxygen percentage go way up. By the time you get to the bottom, to a non-rebreathing mask cranked up to 15 liters, you're delivering close to 100% oxygen. That's the top of the low-flow ladder. Okay, so what happens when that low-flow toolbox just isn't enough? Or what if you're in a situation where you need absolute precision? Well, that's when we need to start climbing higher up the ladder. Meet the Venturi mask. This is a classic high-flow device, and it is just brilliantly designed. Its secret is something called air entrainment. See those little colored pieces? They're designed to pull in a very specific amount of room air to mix with the oxygen flow. And because of that, it can deliver a predictable, fixed concentration of oxygen. So how does it get that precision? It's all about these color-coded adapters. It's pretty genius, actually. Each color guarantees a specific FiO2. You just pick the color for the percentage you want, say blue for 24% or green for 60%, set the flow rate written on it, and you know exactly what your patient is getting. It takes all the guesswork out of it.
Now for a more modern piece of equipment, the high-flow nasal cannula, or HFNC. Don't let the name fool you, this is not your standard cannula. This system delivers oxygen that's been warmed and humidified at incredibly high flow rates. We're talking up to 60 liters a minute. This is a game changer for patients because it's much more comfortable and provides way better respiratory support.
So we've seen all the devices, from simple to complex, but the tools are useless without a strategy, right? This is the most important part. How do you decide which device to use, and when is it time to move up to the next level?
And the process is actually pretty straightforward. You've just got to be systematic. First, you assess your patient, check their saturation. Second, you decide on their specific target range. Third, you start them on the right device. And fourth, and this is the part people sometimes forget, you have to continuously monitor and adjust. You titrate the oxygen up or down to keep them in that sweet spot. It's a constant process.
And this right here is absolutely critical. One size does not fit all. For a patient with a condition like COPD, who is at risk of trapping carbon dioxide, we actually aim for a lower target saturation. For almost everyone else, the target is higher. You have to know your patient.
Let's really zero in on this number, 88 to 92%. This is the safety zone for patients at risk of hypercapnic respiratory failure, like those with severe COPD. Why so low? Because if you give them too much oxygen, you can actually blunt their drive to breathe, which can cause a dangerous buildup of carbon dioxide. In these cases, more is definitely not better. In fact, it can be harmful. Now, for most other patients who are acutely unwell, this is our goal, 92 to 96%. Think of this as the Goldilocks zone. It's high enough to prevent any harm from low oxygen levels, but it's not so high that we risk causing damage to the lungs and other organs from getting too much oxygen. It's that perfect sweet spot. So this is the million-dollar question, isn't it? Your patient is on oxygen, but they're still struggling. What are the clear, objective signs that tell you it's time to stop tweaking things yourself and call for backup? Here are your lines in the sand. Think of these as hard and fast rules. If you need more than 40% oxygen, which is roughly 6 liters per minute on a simple mask, just to keep your patient in their target range, you need to get a senior clinician to see them, and fast. If that need climbs over 50%, or 8 liters on a simple mask, it's time to call the ICU. These are major red flags that the patient is getting sicker. Okay, let's wrap this up by boiling everything down into a few essential practical rules. These are the things you absolutely have to remember to deliver oxygen safely and effectively every single time. Here are the big 5. 1, always aim for a specific written down target range. 2, always treat that SpO2 number as a vital sign. 3, remember, it's a drug, so it has to be prescribed. 4, and this is a big one, if a patient's oxygen needs are going up, that means they're getting worse. And finally, number 5, don't be afraid to turn it down or even turn it off if the patient is stable and above their target. But before we finish, I want to leave you with this one really important warning. High-flow oxygen can be a lifesaver, no doubt, but it can also be a double-edged sword. It can make a patient's oxygen saturation numbers look great, while their underlying condition is actually getting much, much worse. It has the potential to mask a decline and delay a critical intervention. So it all comes back to that very first idea. Oxygen is a precise medication. It requires constant thought, careful assessment, and a whole lot of respect. And that really leaves us with a final question to take away. In your clinical practice, is it truly being treated with the precision it deserves? Thanks for tuning in.